So Shiny will start 7:30.
Yes, madam.
Okay, so good evening, Happy New Year, and a warm welcome to all members of IAPM Kerala chapter, respected senior teachers, faculty members, colleagues, friends, PGs, and all those who are attending this webinar across the country. And a special thanks at the outset to Mindray for arranging the platform for this. So we are starting off a new year, 2025 academics with the webinar on dermatopathology. So this is a webinar series, and this is intended to prime us on dermatopathology, which is the theme for the upcoming IAPM Kerala chapter on February 9th, 2025. So the series will take you through basic approach to skin biopsies. It's designed so that it will be touching upon the almost all the major um lesions related to skin biopsy that we come across in our routine day-to-day practice. Now, dermatopathology is one field of pathology which requires a lot of clinical inputs. So, just like you see your slides under the microscope, it is very important that we see the lesions on the patient. Uh, so, this sort of clinical correlation is of utmost importance. So, the ideal situation will be you see the slide and you see the patient, which is not always possible at a practical level. So I still remember Aravindan sir teaching us when we were PGs, telling us uh, for skin biopsies, you look at the slide first, you jot down your observations, make your opinion, and then you look at the request form that's written by the dermatologist. So most of the time, it should tally. Uh, it should go hand in hand. But then there are some situations where our observations or our histological diagnosis does not go hand in hand with the a clinical dermatology diagnosis, in which case we will need to see the patient. But it's not often practical to call back the patient to look at his lesions. So, what we do in our hospital is that when there is this disparity between the histology and the clinical dermatology opinions, we ask for clinical images. And our dermatologists are smart and they have almost all the images with them. And they send us they forward the images, and uh, basic look at those images will help us most of the cases to give a conclusive diagnosis. So most of the cases are resolved in that difficult cases. So for that we need to know as pathologists we need to know some amount of basic clinical dermatology as to how the dermatologists approach the case. What is their approach to the lesions? How do they formulate their diagnosis? So for that, today we have, I would say, the best speaker. You selected Dr. Abhay. Welcome to Dr. Abhay. He's a senior dermatologist working at Baby Memorial um, Hospital, Calicut. We've been working together in Baby Memorial Hospital for, I think, more than 15 years. He's,
20.
yeah, 20 years. So he's a very shrewd and sharp dermatologist, an extremely gentle person. Uh, and of course, yeah, his requests, or whatever, I mean, when the request comes from Dr. Abhay, it is only one diagnosis and he's spot on. Maximum, he'll have two diagnoses and it'll be one of those. So, so now you understand why we've selected Dr. Abhay. Okay. So, welcome, Dr. Abhay. And one more thing I would like to remember late Professor Sugadan sir uh, when he joined Baby Memorial Hospital. Sir was kind enough to call um, us pathologists to his OP to see the lesions before he took the biopsy. He used to, in fact, he used to help us to understand those lesions. So this is the way it looks. So now you go and see the slide. So that was a very, very important lesson that we all learned in dermatopathology. And that made us realize that dermatopathology is not a big deal once you have seen the lesions on the patient. So today's talk will be exactly on that. And for the formal introduction of Dr. Abhay, I would invite Dr. Shaini, Secretary, IAPM Kerala chapter.
So, good evening and welcome to the first talk of the dermatopathology webinar series, Clinical Dermatology, What the Pathologist Should Know. So, it's my great pleasure and honor on behalf of IAPM Kerala chapter to introduce our distinguished speaker, Dr. Abhay Martin, Senior Consultant and Head, Department of Dermatology, Baby Memorial Hospital, Kozhikode. Dr. Abhay earned his MD Pathology from Government Medical College, Kozhikode in 2003. He's a fellow of International Medical Science Academy. He's a chief editor of IADVL, Textbook of Cutaneous Adverse Drug Reactions. He's the former member, Academy of Dermatology, IADVL, and has contributed chapters to textbooks and national publications. He's reviewer of national journals, key member of the group that give guidelines on Stevens-Johnson syndrome, toxic epidermal necrolysis in Indian scenario. He is a member SIG, that is Special Interest Group, on adverse cutaneous drug reactions. He has presented many papers at various international conferences and about 50 papers at national conferences. Dr. Abhay's areas of interest include clinical care dermatology, cutaneous adverse drug reactions, psoriasis, atopic dermatitis, oncodermatology, and circadian rhythm. So, welcome Dr. Abhay to the talk.
Thank you, everybody, for inviting me over. I deem it an honor and privilege to be called upon to do this onerous task of introducing you all to a topic which I think was the brainchild of Meena Madam. Now, this is a gray area, I would say, because, and it's an expanding margin. As we say in dermatophytic infections, the margin is expanding. So there's no limit to which we can actually say that this is how it should be. So I would like to share my slide. Yeah. So what is the outline of my talk? Basic lesions I'll just be introducing because there's a heterogeneous audience comprising of senior pathologists as well as the junior most residents. So therefore, I'll be dealing with certain basic lesions and what do we mean by a macula, papula, patch, or plaque, or whatever. I'll be peppering my talk with a lot of clinical examples so that you understand the difficulties which a dermatologist realizes and how y'all as pathologists would help to resolve that and how the importance of a CPC. I would also be touching upon bedside tests and also I would be talking about derm path partnership and how that should work.
Dr. Abhay,
Now,
can you
you would
make it
agree
full
that, put on full
Please
screen.
make
Is
it
it
full
on,
screen?
not on full screen? Yeah.
Yeah, now it's okay. Yeah, fine.
So you would agree that both our specialties are visual specialties where we need an eye for detail. We need to memorize a lot of these morphological patterns. Pattern recognition is important in both dermatology as well as in pathology. We do a lot of deductive reasoning and we keep searching for clues here and there, akin to probably a detective or a Sherlock Holmes. We put together the pieces and then finally arrive at a diagnosis. Correlations are equally very, very important in dermatopathology. And we have a host of terminologies. Both our specialties are well known for terminologies. And we have a lot of splitters and lumpers. We try to split them into different diagnoses. And some people say this is all the same. It is all. So we lump them into diagnosis also. And of course, both of us have been affected by invasion of AI because we are a specialty which is very visual and there's a lot of reasoning which is going on. So machine learning is easier experimented on our specialty. But ultimately, what is required is an integrated approach. We look for clinical clues, we do the bedside test, we do the cytology, the HND is done, the IHC is added on based on inputs from the pathologist. We do molecular typing and genetic studies to finally arrive at a diagnosis. So partnership is absolutely essential in dermatopathology. Now, there's something called a silo mentality. Silo for the uninitiated is actually something like a granary. They're huge cans in which grains are actually stored. And all of us are islands of excellence, but we are not joined together to have exchange of information, which can actually make the puzzle easier to solve. So knowledge integration is key in dermatopathology. Now, the first task would be to introduce you all to certain basic lesions. So what is a macule? What is a patch? Whenever I teach the postgraduate students, I say they are younger and elder brothers. A macule, elder brother is a patch. A papule's elder brother is a plaque. A vesicle, elder brother is a bulla. A pustule, we call it lake of pus if it is larger. Of course, nodule, erosion, excoriation, ulceration, petechia, purpura, and ecchymosis are all terminologies which are commonly used. You will be seeing it on your request forms. And macule, you would notice macule, patch, less than 1 centimeter and greater than 1 centimeter. Papule less than 1 centimeter and greater than 1 centimeter. Nodule is usually greater than 1 centimeter. Vesicle if it is less than 1 centimeter, and bulla if it is more than 1 centimeter. Pustule is more often less than 1 centimeter. And erosions and ulcerations can be of any size. Now, this is a typical example of a macule. A macule essentially is a very superficial. It's just an alteration of the skin color or texture. It's usually less than 1 centimeter in diameter, and it is flat to look at. So tinea versicolor is a classic example, and these macules can actually join together to form larger lesions, and that is when they're called patches. So the smallest one would be a macule less than 1 centimeter, and when they join, they become a patch. This is a pigmented macule. There I showed a hypopigmented macule, and this is a pigmented macule, a nevus, and this is a cafe au lait macule, which is usually seen in neurofibromatosis. And multiple macules may be seen, which may be giving us a clue that it is probably a neurofibromatosis. Now, a patch is something which is an alteration of the skin color or texture, which is more than 1 centimeter, and it's a flat lesion. It is not elevated. But having said that, some of these lesions of Hansen's disease are called patches, even though they are slightly raised. Even though there is an infiltration and slightly raised, we call them patches because traditionally Hansen's presents as patches. But by definition, strictly, it is a flat lesion. So this is a typical example of a patch where it is large and enlarged, and we might find a satellite lesion also. So that will give us a clue that probably it is a Hansen's disease, probably a borderline tuberculosis. Now, a papule is an elevated solid lesion, which is less than 1 centimeter in diameter. So it should be elevated, and usually there is an epidermis involvement, thickening involvement, and that is why you get a papular eruption. A classic example is lichen nitidus, and this is how lichen nitidus looks. Multiple studded papules. Plaque is when the elevated lesion is more than 1 centimeter in diameter. A classic example is a plaque of psoriasis, and that is why it is called a chronic plaque psoriasis. And these are all elevated lesions predominantly involving the epidermis. Now, I'll give you a case wherein we find it difficult to diagnose based on, it's a very common clinical problem that we face. Hypopigmented and depigmented lesions. We might take biopsies when these patients are labeled as vitiligo, they're anxious that it is vitiligo, or they want to know what exactly is the diagnosis which is behind these lesions. This is one such case which came presented. This was presented in one of the IAPM seminars, which myself and Dr. Nina had co-hosted way back in 2013. So these were the presentations. Some of them are hypopigmented, some of them are depigmented. So when we see spotty depigmented lesions, of which some of them early lesions may be hypopigmented, and then they become totally depigmented. One is vitiligo, the other is lichen sclerosus atrophicus, and the third is idiopathic guttate hypomelosis. When we see spotty hypopigmented lesions, we think of tinea versicolor, we think of post-inflammatory hypopigmentation. Pityriasis lichenoides chronica, I'll show you the photographs, and of course, hypopigmented mycosis fungoides. Now, I'm showing you the spectrum of lesions. They all are hypo to depigmented. That is why we need a diagnosis in these cases. So this is vitiligo. These two are lichen sclerosus atrophicus. This is on the leg, idiopathic guttate hypomelanosis, and pityriasis lichenoides chronica is classically seen on the trunk. So that is a clue for us that it is PLC. So when you all look at the report and you see that the request form has a truncal lesion with hardly any lesions elsewhere, one would be justified clinically to think of pityriasis lichenoides chronica. But vitiligo, we cannot say the same thing. LSA, usually it's a localized patch or plaque, and that is what gives us, and there is atrophy involved. So this is a close-up of that lesion, a vitiligo lesion. Lichen sclerosus atrophicus, you can see a glazed appearance here and multiple small group lesions. This is elderly, you see scattered here and there depigmented lesions. And this is classical pityriasis lichenoides chronica. Here you will find hypopigmented lesions, but initially they will start off as small papular eruptions. They become scaly and then they leave behind a hypopigmentation. But when this sort of a distribution is seen, we call it as pityriasis lichenoides chronica. Now, this case had differentials, the same differentials which I spoke about, we had in mind. So the pathologist has to resolve this conundrum. These were the histopathological specimens, which opinions which were given across the state. Hypopigmented MF dominated in 7 cases, but there were other. But of course, there is a strong possibility of a malignancy here, which would have gone unnoticed had not a biopsy been taken. That is where the indication for a biopsy comes here. So you can see this lesion wherein the epidermotropism can be observed, and you can focus on these scanner viewpoints, and you will also see the atypicalities occurring. So this gives you all a clue that it is probably a CTCL or a hypopigmented mycosis fungoides. So for us, the differentials in a CPC will be what are all the hypopigmented lesions with lichenoid infiltrates we need to know, similar to the clinical diagnosis we see. And then finally, in this case, these salient features where clinically hypopigmented lesions were seen, lichenoid infiltrate with string of beads sign, epidermotropism was seen, and then the IHC panel was run because the pathologist asked for it. And then because it was CD2, 20 negative, 30 negative, CD3 positive, CD5 positive, CD7 negative. So a diagnosis of hypopigmented MF was. So that gives us a clue. And then we actually go in for phototherapy and methotrexate initially. And sometimes we go for much more immunosuppressive medications. So detailed evaluation will also be required in this case for systemic involvement. So that is where the pathologist comes in. So we have so many clinical differentials which we met. This is another case interesting because this is actually multiple, looks like hypopigmented lesions, but to a discerning eye, one would realize when we use a hand lens or when we use a dermoscope, we realize these are actually slightly raised lesions. They are not flat lesions. So the initial clinical diagnosis may be hypopigmented lesions, but the importance of examination with the hand lens is shown. And the clinical differentials would have been all of these: tinea versicolor, vitiligo, LSA, idiopathic guttate hypomelanosis, and even. But in this case, because it is a little more elevated lesions, we'll put a diagnosis of plain warts or an epidermodysplasia verruciformis, which is a heritable form of warts where you can have a relative immunosuppression. So these two diagnoses would be dominant on my list instead of the ones on the left. So the histopathology opinions in that slide seminar, they all gave epidermodysplasia verruciformis with Bowen's disease. These were the slide pictures which you can see. You can see the coilocytes and you can see atypical cells in certain focal areas. So another zoom picture to emphasize this particular point. that it is actually you're dealing with a wart-like lesion. This is not a typical wart. You are having lot of flat plain warts. So hypopigmented lesions with large pale keratinocytes, enlarged nuclei, and foci of severe dysplasia and with squamous cell carcinoma in situ. So this was the final sign-out diagnosis. So again, you see that what could have been presumed to be clinical diagnosis of tinea versicolor or other conditions has finally turned out to be a EDV, and the pathologist has clinched the diagnosis for us. So a discerning clinical dermatologist will look at use a hand lens or will look at the distribution and then be able to diagnose an EDV or a plain wart there. Now, this is something which initiated this whole talk. What is an infiltrated plaque? This is a classical infiltrated plaque where there is an accumulation of an infiltrate into the dermis, and that is causing an intense swelling of the dermis, and the epidermis is also being swollen up in different areas. But there are certain areas of crusting also seen. If I had looked at it, this is actually a journal case, but here I'm representing this here because it gives a lot of learning. What would have been my clinical diagnosis differential if I had seen the patient directly? I would have thought probably it's a case of photodermatitis because there is so much of intense inflammation on the forehead. It's a photoexposed area. It could be an irritant. Patient has applied something that can also cause edema, which spongiotic lesions can occur. So both of these, I'm expecting a spongiotic lesion. Or it could be a Hansen's reaction. There was a previous patch there, and that has gone into a type 1 reaction, or it can be a sarcoidosis probably, which has undergone an inflammation. Very rare that sarcoidosis undergoes this sort of an inflammation. Lymphocytoma cutis and cutaneous lymphomas, it's a very big mimicker, and therefore we'll always be alert to this possibility of a lymphoma. So if I were to write my differentials, I would say photodermatitis, irritant eczema, Hansen's reaction, and cutaneous lymphoma. Those would be my diagnosis. But this is actually a quiz case in our journal. And when you look at the pathology here, and that is what gave the diagnosis, there's an infiltrate of lymphocytes and plasma cells, which is quite significant, which is not usually seen in any of these conditions. And this was a stunner because this patient actually, they took the history, they gave a VDRL because he was sexually active, they gave a VDRL that came negative. But since the pathologist gave the possibility that there is a secondary syphilis is a possibility, they did a repeat VDRL and the histology favored syphilis, and therefore they were able to diagnose that it was a late secondary syphilis, which is a very, very unusual presentation. This is unusual. This is not the usual presentation of syphilis, but unusual things will be picked up only when a biopsy is done, when the clinical suspicion is high. So this is the importance of a liaison here. Now, this is another set of infiltrate. This is our own case from our dermatology department. This is a 56-year-old housewife. She presented with these raised lesions over her face and neck, 25 years duration, slowly progressive, largely asymptomatic, mild pruritus. Raised lesions over her eyelids of 4 months duration, difficulty and painful movement of the joints with hoarseness of voice. When we look at this sort of lesions, we think of certain possibilities. I'll come to that. Non-diabetic, non-hypertensive, non-asthmatic, no similar complaints in the family. This is what we call a leonine faces, almost like a lion-like face. But there's so much of woody induration in that patient. And if you notice carefully, very carefully, there are multiple discrete small waxy papules, which is better appreciated on the forehead. And here you can see it. These are the lesions from which a biopsy should be taken because these are early lesions. They have not joined together to form a larger plaque like this. So when you're asking the clinical dermatologist, ask them where the biopsy was taken from. And early lesion should have been picked up. And of course, you can see the infiltration in the periorbital area and cheeks, the right and left eye. And we had a working diagnosis of probably mixed edema, lipoid proteinuria because there was hoarseness of voice. So both can present, mixed edema and lipoid proteinuria can present with hoarseness of voice. And of course, cutaneous mucinosis was one of the differential diagnoses because there was a presentation of waxy papular eruption. And we investigated, all parameters were normal. Thyroid function test was also normal, but she had elevated triglyceride and a skin biopsy was done. And lo and behold, we had the diagnosis, a sheet of blue. It is a sea of blue, and we knew that we are hitting upon a mucin deposition. So it was a cutaneous mucinosis. And finally, we did the special stains on this, and then it was signed out as lichen myxedematosus bar scleromyxedema. We gave the treatment as for scleromyxedema, patient got better. So there you find the importance of the doing the special stains as well as the clinical differential diagnosis, how we approach. This is another infiltration. Here you're seeing slightly elevated lesions, and for us, this is almost a clincher diagnosis. This should be Hansen's disease because that coppery red appearance you can see. You can see multiple small lesions which are actually joining up together to form larger plaques. Some of these lesions are so raised, and there is earlobe infiltration. And this cotton which you're seeing here is actually a slit skin smear was done. So we have clinical differentials here of Hansen's disease, a remote possibility of sarcoidosis because sarcoid and Hansen's can be great mimics. And the third mimic is lymphoma. Sometimes lymphomas can present this pattern. So we will probably put that. But in Hansen's, are we dealing with LL or a BL? Because LL and BL are the ones which produce asymptomatic lesions like these. So that history is important. Usually in BT and TT, patient presents with a little more florid presentation. There will be anesthesia or hypoesthesia. There will be neural involvement. There will be wrist drop. There will be palsies. Because the immune system is actually destroying the nerves and the tissue, you will find ulceration at times also. But in a lepromatous, the patient will continue to have these lesions asymptomatic. So he'll carry it and he'll give to others too. So he's infectious. And with so many infiltrated lesions, I have to think in terms of a lepromatous leprosy. Now, this was the path differentials which were seen across the state. So most of them said it was a Hansen's BT with type 1 reaction. Some said it is a borderline. And even some went to the extent of saying it's a borderline lepromatous with Lucio. So which holds good with the clinical diagnosis that is probably a BL. Now, this is the histopathological picture. I'll just give you some time to assimilate this. You can see that is a Grenz zone here. And the Grenz zone is usually seen in the lepromatous spectrum. But there is some amount of ill-defined epithelioid, granulomas which are being formed. We are looking for periappendageal perivascular inflammatory infiltrate. So this is a close-up of that histopathology. So weight fight is naturally done because we are thinking of lepromatous. So very minimal. Now you have the salient features. So normal epidermis, a Grenz zone, ill-formed epithelioid granulomas, no giant cells, scanty lymphocytes, nerves are normal, and bacillary index is only 0 to 1 plus, which is quite surprising with such a gross infiltration. So this table then comes into picture. So what happens? Epithelioid, normal nerve involvement, 0 to 1 bacillary index, epidermis normal, giant cells are there, and Grenz zone is present. So the diagnosis was given as Hansen's disease, mid-borderline. Here there will be a discrepancy with our diagnosis because we would be thinking in terms of a lepromatous. However, the treatment will be multibacillary. Here the disease spectrum itself is confused between whether it should go towards tuberculosis depending upon his immune system getting better, or it goes downward when his immune system is actually getting worse. So lepromatous spectrum you will find so that's why we call this a watershed, where mid borderline is something which the disease as well as the consultant is confused as to where exactly to position. And you will see that the disparity is quite high across studies. So ranging from 50% to 71.5% in clinical pathological disparity. So when we look at this sort of a patient also, again, some amount of hypopigmentation, some amount of infiltrated lesions. A close-up of these lesions, this I would have diagnosed clinically that 3 differential diagnoses. I'll just show those diagnoses. I would have thought probably a disseminated discoidally. Sarcoid can have very variable presentation. This can present like this. I would still think of Hansen's disease, but Hansen's would not have so much of central atrophy. As you see here, there's a central atrophy. So the early lesions are what we always look for. And of course, Dego's disease, which is a rare thing, which presents with abdominal plane associated malignancy sometimes. So there we can have also a similar presentation with central atrophic center. So you will see this presentation. You can make out central depigmented areas can be seen in annular variant of sarcoidosis, in discoid LE, and in Dego's disease. So this would be a differential. But they did a GMS and found spores. They found fungal etiology in this. And they did a PAS. And then they finally gave a diagnosis of histoplasmosis, which is a total surprise for everybody. And they also considered Penicillium arnaffi as another possibility. So there are reports of these lesions presenting like these as small elevated papular eruptions, which hypopigmented, it looks like hypopigmented lesions, but actually when you closely examine, they are actually minute infiltrations of the. So the diagnosis there with along with the fungal culture was histoplasmosis. So there again, the clinical pathological conference has actually helped. Now coming to a nodule is unlike a papule, is actually arising from the dermis and it is pushing the epidermis up, and that is how a nodule develops. So therefore, when you see a case like this where multiple nodules are seen, I would have, when I would have a look at this case, I would think of differentials like maybe I'm dealing with neurofibromatosis, I'm dealing with Hansen's disease, sometimes hystoid can present like this, or I may be dealing with a sarcoidosis, or even xanthomas can present like this. So this will be the presentation of these four. Very rarely, pearly white papules with central amplification would be the classical presentation of molluscum contagiosum, but none of them have a central amplification here. So molluscum is pretty much ruled out. And lymphomas, again, I said it can mimic, but we'll just put it at one differential diagnosis. So this is how we work at a diagnosis. This is actually from a journal, atypical variants of leprosy, and this was actually hystoid leprosy. The final diagnosis was signed out of hystoid leprosy. Now, this is a presentation of some other nodular lesions for your benefit. Lymphocytoma cutis presents as very discrete nodular eruptions like this. And this is actually a cutaneous lymphoma, probably anaplastic. And you can see the central necrosis which has occurred, a hemorrhagic necrosis, and the crateriform lesions which you are seeing. So this is very classical of a cutaneous lymphoma. Now coming to vesicles and bullae. So a vesicle is a fluid-filled lesion which is less than 1 centimeter in diameter. This is a vesicle, classical, and this is a bulla where the fluid-filled lesion which is more than 1 centimeter in diameter. It's a clear fluid. So commonly seen differential diagnoses are these which are put up in your request forms. But there is no formal classification of distinct diseases of the skin. So I have an arbitrary classification which I use: non-autoimmune, autoimmune, and genodermatosis. Non-autoimmune, injury related, like physical injury, thermal injury, or mechanical, infection related, varicella, HFMD, herpes zoster, and even sometimes eczema can produce like pompholyx or allergy. Autoimmune disease, host of pemphigus group and the pemphigoid group, and genodermatosis like epidermolysis bullosa and incontinentia pigmentosa. But definitely in this you will have a history that's a childhood disorder and progressing sometimes into adolescence also. This pemphigoid, especially bullous pemphigoid, we would see it more often in the elderly, and you will see larger lesions, larger bullous lesions, extremely itchy. They start off as small itchy lesions. So if your clinical dermatologist is smart enough, he might even pick it up when these lesions are presenting as urticated plaques. Actually, they are a mimic of urticaria. They can be seen on the inner thigh and the lower waist pattern. And then they become bullous and become larger lesions, bullae, and then they crust, erosions form, and then they crust and they. So, and whereas these are very superficial erosions, that is pemphigus. So superficial flaccid bullae should make a diagnosis of pemphigus. So of which of these types is decided by the clinical morphology, the distribution of the lesions, as well as the IF studies. So foliaceous vegetans is usually seen in the flexures. Foliaceous, you will have a seborrheic distribution related to the interspinal area, the scalp, and the intermammary area. Vulgaris, usually again you will have mucosal lesions more often seen along with the skin lesions. Paraneoplastic, you can have even lichenoid lesions occurring in these. So based on that, clinical input will. But the final diagnosis is an integrative diagnosis. It is skin lesions plus HND plus an IF study. So when you see the split occurring within the epidermis and you see this fishnet appearance, the diagnosis will never be missed. And you can even see the intraepidermal vesicle formation. Now, for the uninitiated, this is how dermatitis herpetiformis presents. Patient present with intense itchy lesions over the elbows, the knees, the buttocks. And if you're fortunate enough, you will be able to find small microvesicles. So those microvesicles which rupture are the ones which leave behind these excoriated areas. So because the patient has so much of itch, intense itch, they will excoriate the area and cause this sort of lesions. But your IF study will actually help you to diagnose where there will be in the deposits in the papillary, dermal papillae. Now, I was mentioning about non-immunobullous. See, this is pompholyx or sago grain-like appearance, which you see in pompholyx in the finger. So when a diagnosis is not possible and patient is having recurrent lesions, they might send you a specimen. You would see a spongiotic dermatitis. So you can safely put it as spongiotic dermatitis because all of these lesions end up with a spongiotic appearance, and the lesions will show intraepidermal spongiosis. Varicella, it's easier to diagnose with a Zank. Usually we don't do a biopsy for varicella. Another case where there was actually superficial erosions. So somebody who is not introduced to dermatology will say this is probably a childhood pemphigus because there are erosions, there are bullae formation, very flaccid bullae. But what is important is the child is very irritable. It is a short duration febrile illness and skin is peeling around the orifices. It occurs around the eyes, it occurs around the mouth, it occurs in the flexural areas. It will also be there in the groin area and the perianal area. And paradoxically, when the child is picked up by the mother, the child cries a lot, which means that the skin tenderness is there. And when the skin is tender to touch, and the patient is looking toxic, one has to think of a diagnosis of SSSS, that is Staphylococcus scalded skin syndrome. But here, the clincher is not a biopsy, it is a bedside test. So the clinical dermatologist who knows the diagnosis will want a Zank smear for this. And within 2 hours, we are able to diagnose this and we can initiate treatment. So this was a Zank of that patient. And you can see the acantholysis which has occurred in this. That is because of the toxin, the exfoliated toxin which occurs with staph. So no histology is required to diagnose this in this case. So this is another area spectrum from no biopsy to biopsy mandatory and sometimes doing serial biopsies. A pustule is a lesion less than 1 centimeter in diameter and usually is pus filled. A vesicle is clear fluid. A pustule is pus filled. And you have a host of differentials which we give. Pustular psoriasis. In this, there will be previous a psoriatic patch or a plaque which has undergone a transformation to form multiple small pustules. That is one. That is usually occurs in a patient who has been inadvertently been given steroids. And you withdraw the steroids, they go into pustular psoriasis. Or the patient has applied an irritant, sometimes an Ayurvedic medication, or patient may be put on some irritant medications. Even our own coal tar can sometimes cause irritation. Some people use salicylic acid and that can cause irritation. So if irritant reaction occurs on a psoriatic patch, you can develop pustular psoriasis. Or sometimes you can get a de novo pustular psoriasis without any trigger. Acute generalized exanthematous pustulosis, you will have a uniform sheet of pustules occurring in a crop. And that usually occurs more often with a drug. Like for example, the penicillin drug, you have given ampicillin, amoxicillin, and then within about a week, a day or two, or maximum a week, a shower of pustules develop, and simply stop the drug and give a short course of steroid to patient. But to differentiate between pustular psoriasis and AGEP requires clinical acumen. And that is where you all would come in with the diagnosis. Another commonly asked requested diagnosis is Sneddon-Wilkinson or subcorneal pustular dermatosis. Usually it is seen in females in the flexures, in the inframammary area, and you can see regional pustular eruptions. So this is just to introduce to the morphologies of what a typical case is. Miliaria is another thing. It is a heat rash where there is an obstruction of the sweat gland. The most superficial one is called miliaria crystallina. The next level is called miliaria rubra, where you get redness and itching, and miliaria pustulosa when the neutrophilic infiltrate occurs. So depending upon which specimen is given to you, because miliaria pustulosa is often given as a differential to SCPD. And even cutaneous candidiasis. So when you're doing a biopsy, sometimes you might find a fungal hyphae, fungal pseudohyphae, and then you would ask for a fungal stain and then you see candidiasis. So you would report it as candidiasis. Candidiasis could be actually a colonizer there in a eroded skin, because wherever there is erosion and maceration and wetness, you can actually. So whether the candidiasis is a disseminated candidiasis, one should ask the clinician, because disseminated candidiasis means the patient is profoundly immunocompromised and he's developing a shower of candida lesions, pustular lesions all over the body. Whereas if it is in a regional area, one should be thinking that it is only a localized colonization by candidal infection. Coming to purpura, another diagnosis which we often see. Purpuric means extravasation of blood into the upper dermis. So you can have purpura with some amount of hemorrhagic necrosis in the center, or you can have a shower of purpura like you see in Henoch-Schondlian purpura or a thrombocytopenic purpura. So how does a clinician approach this? First, he looks at whether it is a palpable one, a non-blanching, or a non-palpable one, which is a blanching. We do something called a diascopy test. We take a glass slide and just apply pressure on that. And if it blanches, it is only erythema. There is no purpura. If it is purpura, there will be non-blanching because the blood has actually drained into the dermis. It's a rupture of the blood vessel which has occurred. We also look grossly whether it is a thrombocytopenic or a coagulopathy associated, like we might see in a DIC or an ITP. Or we also ask whether it is a eruptive lesions, multiple eruptive lesions coming in a sudden onset and recurrent episodes. HSP, Henoch-Schondlian purpura, can present like that. We always ask other systems. So when you have a slide, request form, always ask the clinician to include history of other system involvement like joint pain, abdominal pain, renal involvement in the form of hematuria, or a CNS disturbances, mucosal involvement, which may be part of a thrombocytopenia, or a pulmonary involvement, a sudden hemorrhagic episode. All of these are important inputs, which only if you call up the clinician, you would get those histories. And of course, underlying pre-existing comorbidities. Like for example, a person who's diabetic gets an infection and suddenly going for a HUS or a HSP might actually present with this sort of, or a DIC or a sepsis can present with this sort of an acute presentation. So we usually ask for investigations, the hemogram, urine routine to identify if there is hematuria, even microscopic, peripheral smear, because are we dealing with something ominous? Even hematologic malignancy. We ask for a skin biopsy with IF if it is a palpable purpura, because we may be dealing with a vasculitis. And of course, as is mandated in vasculitis, we send for ANA, IF, and ANA profile, and sometimes even an ANCA. This is a case report which we published. It was actually this lady went to her native place where they had a farm, and she went up the uphill and she got a scratch by a plant she remembers, or an insect which she is not very sure about. But within 1 week, she developed a florid fever, and then she went in for purpuric eruptions developing, and some of these areas became very necrotic. That is where the first injury occurred. Now, what I wanted to impress upon here is the importance of where to take the biopsy from. Biopsy should always be taken from an early lesion as high up as possible, and it should preferably be taken from a very small lesion. The earliest lesion should ideally be taken for a biopsy. So if the clinician diagnoses vasculitis and your biopsy does not correlate as vasculitis, ask where the biopsy was taken from and what is the presentation. When you look at the clinical photograph, you actually realize. So if you take something from here, a biopsy from here, you're likely to get only ulcer with granulation tissue or a erosive lesions, erosive dermatitis with some neutrophilic infiltrate. So this will not give much value if the biopsy is taken from here. But on the other hand, if it is taken from an early lesion, you will always get a classical picture like a leukocytoclastic vasculitis. Now coming to ulcers, there are 3 terminologies which are used. Erosion, it's a superficial break in the continuity of the skin. An ulcer is a deep break, and an excoriation is a linear break in the continuity. As we see in patients who have scabies and all, they actually excoriate with their nails. And that is how you get a linear break in the continuity. And sometimes you might get leg ulcer as for diagnosis, because pyoderma gangrenosum is something which is quite often missed and overdiagnosed sometimes. Venous ulcers, you can see the venous congestion in the blood vessels. Ischemic ulcers, especially livedoid vasculopathy, that is one place where you have both. You have a venous stasis, you have a lipodermatosclerosis, you can see the pigmentation here, and sometimes patients present with very, very well-defined small ulcers which are exquisitely painful. That gives a diagnosis that is a vasculopathic or an ischemic ulcer, right? Whereas here, this is only venous stasis which has led to congestion and then reduced oxygenation and causing ulceration. So this is a classical venous ulcer. Now, this is an interesting case of a 65-year-old gentleman. He was admitted under pulmonology for an episode of epistaxis with hematuria. And they found on radiology that there was a pleural nodule close to the mediastinum. And they sent me a reference for scrotal ulcers, micro ulcers, and on the elbow. So when I looked at it and I asked whether there are any other renal lesions which they were suspecting, renal pathology, nephrologist was called in only. But because there was an episode of epistaxis with hematuria and there were vasculitis-like lesions here, and the mediastinum is involved, I thought of a midline lesion. And that gave me the clue that the referral should be, one should think of a midline lesion with these symptoms. One should do a skin biopsy, and promptly it came as a vasculitis. Day 3, the CT lung report, as we had thought of, came as vasculitis, and the final diagnosis there was actually GPA, because we thought of granulomatosis with polyangiitis because of the midline lesions as well as the vasculitic presentation. So a very subtle manifestation of vasculitis which you are seeing here. This patient, actually, we started on immunosuppressive methylprednisolone pulse, and then he came back with a glomerulonephritis and then renal failure, hematuria, and then he was put on rituximab. Now, apparently, he is doing well, but he is on follow-up. Now, a word about bedside tests. This is part B of my talk. We do 4 bedside tests, which is essential knowledge for all pathologists: Zank smear, superficial skin biopsy, slit skin smear, and aspiration cytology. This is the Zank smear I spoke about earlier. If you are doing the Zank smear yourself, I just run through the steps. You should always select an early vesicle, and you de-roof the vesicle using a surgical blade, number 11 blade. Just de-roof the vesicle, extrude the fluid contents. So you just keep a gauze here by the side, and that will actually, by capillary action, it will draw out the fluid and scrape the floor of the blister. And then you stain it with that, you smear it onto glass slide, stain with Leishman or Giemsa, and look for whatever the diagnosis that has been given by the clinician. If it is a suspected chickenpox, you can get an MNG cell or in a viral case, and acantholytic cells in cases like these. Now, superficial skin biopsy is something which is quite unique. These are the things which we need for a superficial skin biopsy. We usually take anesthetic ether because we use it as a good degreasing agent on the skin, because there is so much of oiliness of the face in patients with dermodecidosis. This is actually done for dermodecidosis. We use super glue. We have glass slides. You have a small artery forceps, a cover slip, and cedar wood oil for a good resolution in the 100x. So after we degrease the skin, we place a small bit of super glue on the glass slide, and then we place it. It holds on like this on both sides, and then we gently ease it out. We never pluck it out. We just ease it out with an artery forceps slowly, and this is what we get as a tissue on the glass slide. And we put a cover slip, cedar wood oil underneath, and then we examine under the microscope. Some people have actually modified it where they put a 1 square centimeter area where, so that you actually can count the number of demodex in a 1 square centimeter area. So if the total number of mite in 1 square centimeter is more than 5, it is considered a positive, and it is not a commensal, it is actually a infestation which has occurred, and that should be treated. This is how demodex looks when we do a superficial skin biopsy. It will be jetting out of the hair follicle, and this is how it looks on the dorsal and the ventral side. And this is a resident within the hair follicle, and therefore when you do it on the face, you get a lot of these mites. This is the clinical presentation of a demodex, either as an erythema or small papulopustular lesions. They look very similar to acne, but acne usually does not occur in this sort of an area. This is more adjacent to the nose, the ala of the nose and the cheeks, and plenty of demodex. This patient actually had this. This is a snapshot of this patient who had plenty of demodex floating around. And this is actually a video. I do not know, madam would remember this. Way back in 2004, when I joined, this video was taken. And you can see the mobility of the demodex. the legs are moving. So this can be done with a superficial skin biopsy. And these are the microscopic images which will actually help you. And you can see that jetting out of the follicle. This is a florid presentation. In such cases, you will not find Demodex high positivity because the inflammatory reaction is very high. So you can get a Demodex negative with it. But this also is a profound inflammatory response. So they allow the inflammation to settle down, and when the erythema is there, you do it. The other one in Hansen's is a slit skin smear. Here, the earlobe is a common site of infiltration in the lepromata spectrum. That is why we do it here. So an incision is made on the earlobe, a linear incision. First, before that, that fold should be gripped firmly between the thumb and the forefinger and make it avascular, blood-free. And then you make a small incision and linear incision. And then the blade is turned 90 degrees at the end of the area. And from there, scraping is taken, and that material is smeared onto a slide. And that will, if it is AFB is positive, you will develop an index. So that is how a slit skin smear is done. So this is done in suspected Hansen's disease. So easy, and even actually it is given to leprosy technicians to do. Even in peripheries, it can be done. Picks up the diagnosis very fast because biopsy may not be amenable to every time. So now you do realize when and why a dermatologist asks for a biopsy. When he's unsure of a diagnosis, hoping for HPE as a clue, he has a known diagnosis, but he has to document it for medico-legal reasons. Especially when we give a diagnosis of Hansen's, vitiligo, psoriasis, patients get a little perturbed or even a malignancy. So that is when we need, for medico-legal reasons, we might, even though we know it's a classic case of Hansen's, we'll do a biopsy. At least as of now. Earlier, empirical treatment was allowed, but now without histological diagnosis, we cannot venture into that. When we are planning long-term immunosuppressors with adverse effects, we always make it a point to biopsy. An example I will tell you, in lichen planus pigmentosus or in lichen planus, we do a biopsy because we want to give them immunosuppressives at times. So lesions where we are planning something like that, we will definitely. To select a line of treatment, like it can be as a part excision, diagnose with HPE, and then do a complete excision, or it could be. Can you give me a minute? I'll just plug the PC. Just. Yeah. So, or it can be biopsy as a treatment where we do a wide excision with margins, a staged excision, and to diagnose by benign, pre-malignant. And so there are three types of biopsies which are done: a shave biopsy with the blade, where the lesion is actually shaved off; a punch biopsy with a punch instrument, and an incisional or an excisional biopsy where we use a scalpel blade. There are several indications. Any reference on the net will tell you this. These are the instruments which we use for an incisional biopsy, and this is the punch, which is we just rotate, and this contains a circular blade which will dig even up to the subcutis. So a punch biopsy has its advantages and its disadvantages. So we use depending upon where we require. So we might do a punch excision, we might do an elliptical excision, we might do a punch biopsy where we want a partial sampling to be done. One message which I want to put across again is in vesiculobullous disorders, where to take a biopsy from. A routine histology HND should be taken from the margin of the blister, so that some amount of normal skin is. But when we're taking for DIF, always take it from outside, 1 centimeter outside. So if you're doing biopsies by yourselves, or if a dermatologist is doing a biopsy and has sent you a specimen, but it is not correlating, ask how the biopsy was taken. That may give you the clue as to why it is not correlating. Then in DLE, many people do the mistake of taking a biopsy from the center. You are going to get atrophy in the and fibrosis in the HND stage. So it should always be taken at the lesional margin and should be taken from an early lesion if possible. Usually we don't do DIF for DLE unless it is a DLE with an SLE. We might. In SLE, HND, when you are seeing a subacute cutaneous LE or a maculopapular rash, we always prefer that it is done from the lesional skin and preferably a larger chunk from within the lesion and a smaller chunk of the normal skin. But in vasculitis, we always, as I mentioned earlier, early lesion should be taken, should be less than 24 hours old. And if it is in the lower limb, always prefer the thigh or the upper part of the leg, and only later give an option for forearm. So the higher the lesion, the better, because redundant or dependent areas tend to give false results. IF, if you're doing a lupus band, which is now a little outdated, but if you're doing a lupus band, always do it on a non-exposed photo protected area like the buttock. Uninvolved skin must be taken for lupus band test. In Hansen's disease, again, lesional skin, infiltrated margin, and more towards the center. Many people do a biopsy at the margin and then end up with more normal skin and less of the lesional skin. So always better that the biopsy is done with a significant chunk taken from the lesional area. This is another disease where biopsy handling is very important. We should not use a local anesthetic with epinephrine or adrenaline in this case. So usually for biopsies, we give a local. It should not be given with epinephrine, which will degranulate the mast cells and a false picture comes. And you should always inject an anesthetic agent near the biopsy site, not directly into it. So somewhere closer to the lesion, but not into it, because that again will degranulate the mast cells. And some people do a topical anesthetic cream applied or a vigorous rubbing like with surgical spirit. That also can alter the histopathology. So don't apply plasters or adhesives to lesions. And this is the classical Darrier sign. So if you have the option of seeing a patient with suspected urticaria pigmentosa or a mastocytosis, you can elicit a Darrier sign using an eraser and just rub it gently and you will see erythema in the Darrier. Now coming to the last slide of my presentation, dermatopathology partnership, where are we heading? Always correlate signs and symptoms with the findings. And clinical photographs add a lot of value. I have given you ample examples where clinical photographs have actually helped us to diagnose. Close examination, close lab, discuss and rediscuss clinical clues. Never be isolated from the clinician. And specialized tests when, why, and how, interact with the clinician and suggest suitable ones as you proceed. Your clinical histological correlation lies on your inputs towards these specialized tests. On a personal note, I feel there is no harm in offering pathology differentials. It is not always possible to give a single diagnosis to the clinician, and the clinician may pick it up from those and then decide about the final diagnosis and the mode of treatment. So it's okay to give a pathology differential, because what you all see is like a photograph. What we see is like a video. We see the continuous spectrum of lesions. We know that the biopsy site may be different. It should not have been the ideal biopsy site, or it could be that the disease is in evolution. And therefore, what you all are seeing at that point in time may not correlate with the clinical diagnosis. So what you all see, you all can definitely give us a pathology differential. And it's good to know treatment options, because I'll give you an example. Prurigo nodularis and a hypertrophic lichen planus both look somewhat similar clinically. In prurigo nodularis, I would be giving either a topical corticosteroid with an intralesional injection. In hypertrophic lichen planus also, I'll be giving an intralesional injection, but I might put the patient on immunosuppressive therapy. In prurigo, I might give something called a phosphodiesterase inhibitor like apremilast. So that treatment option differs, and therefore the biopsy may be required for diagnosis. But when you all know what is the treatment option, you are giving intralesional for both. So it doesn't make a difference. So why did you biopsy? Because we want to suitably take a treatment option. So very close to clinical differences, it's good that the pathologist also knows treatment options. And especially when you're handling ambiguous cases, always make it a point to liaise with the clinician and that we speak as one voice to the patient. Because I invariably make it a point that one clinician, if we are in a multidisciplinary, one clinician does the passing on of information to the patient. Thereby, we know at back end what is happening at the pathology level or at the diagnostic level. So it's always better that one person actually handles that, the primary consultant, or if possible, the inputs can be collective, where you can discuss with the pathologist and the radiologist and the clinician. Follow-up and redos should be communicated to the patient well in advance if you are doing that. And when you're handling second and third opinions, make sure that uh, adverse comments about the handling are avoided. Adverse comments about the clinician, adverse comments about how the specimen was handled, the biopsy was taken, all these things are, they are waiting for clues. What we have seen as patients are waiting for clues to add insult to injury or stoke a fire. And you should also be co-partners in costing and finance. Very often, some of these patients are very poor. They have done a lot of investigations and they are drained. So a little bit of reduction and costing actually goes a big way in diagnosing and helping them out. And of course, we should have mutual respect and professional empathy. All clinicians have one aspect in mind, that is the patient benefit. So professional empathy is something which I am very, very particular about. I'll leave you with this last case, where a recent one where I was a pregnant lady presented to me with multiple discrete and confluent skin colored circinate plaques on the hands, forearms with minimal itch. She was pregnant. She was referred by the gynecologist. They had done 3 biopsies earlier over the last 2 years. First biopsy was insect bite reaction. Second biopsy, suspected cutaneous T-cell lymphoma. Third biopsy was inconclusive. And I did a 4th biopsy from PMH. An extraordinary issue was happening. And the patient was unsure which of these biopsies should be trusted in. So these were the lesions. They are actually patches, pigmented patches, you can see, but there is a margin here. When you see a marginated lesion like this, one would think probably it is a treated case of tinea corporis, which is actually healing with a hyperpigmentation. But there is also a possibility called erythema annularis centrifugum. And of course, if this margin has a very thick border, a beaded border, what we call, then we think of granuloma annulare. So that was there on my list. You would see the first of them was granuloma annulare, because that was not thought of at that point in time. Then tinea corporis and erythema annulare centrifugum were my other differences. And this was the lesion on the forearm and on the dorsum of the hand. And she's around third month pregnancy. Now, to rule out MF was included here because there was an earlier diagnosis of MF. Now, the biopsy has actually, I didn't get the slides. I didn't get hand for the slides. See, the dermis shows moderately dense perivascular infiltrate of lymphocytes and eosinophils with scattered interstitial eosinophils, which is very unusual presentation for any lesion. And I got a whole new diagnosis called eosinophilic annular erythema. This was the first time I'm encountering this particular entity. And the back end was done by the pathologist. This is a textbook, a web picture of how erythema, eosinophilic annular erythema is seen. Just started reading about it. And I find that there is some amount of correlation. A host of pictures are there. So we go into deeper learning. And we plan for a CPC discussion. The moral of the story is learning continues. Both sides, we learn a lot. So this was a lead which made me learn about. So likewise, I hope I have been able to teach you all something about the difficulties of a clinician, the difficulties of a pathologist, and finally, how we arrive at a diagnosis for the benefit of the patient. I think I've given you food for thought. Dermatopathology is all about intellectual humility. It's an opportunity for partnership and friendship, not one-upmanship. So that, I think, would be my take-home message. Thank you for your patient listening.
Thank you very much, Dr. Abhay. And that was exactly what we expected from you. I'm sure all the pathologists here share my opinion here. Any questions? Anyone has anything to ask Dr. Abhay?
Madam, there is one question.
Yeah, there is one question in the chat box.
Yes.
Okay.
If the time permits, should I read the question?
Yeah, you can read the question then.
Okay. What is the test done was scabies, skin scraping or adhesive tape test? Which is better?
Yeah, skin scraping would not actually yield much in scabies. What we need is to identify the burrow, and we have to take, erode the inside the burrow and then take out those scrapings and put it on the glass slide and see if you can find a scabies mite. Usually, there's a small papule or a pustule, very faint whitish beadish sort of appearance, small one. You open that and then scrape it, and then you will get. Some people actually have got it like the superficial skin biopsy. Some people have used a cellophane tape and then got. But these are all hits and misses. We have to use it, but ideally would be to actually explore the burrow and get it out. The papular eruption which you see at the end of the burrow is what will give you the diagnosis.
Thank you so much, sir, for addressing the concern.
Thank you.
One more question is there. Sometimes we don't see any specific findings, even though the lesion is extensive. Why is it that?
See, the reason could be multiple. One, it is an eczematous dermatitis. The time of when that biopsy was taken may not be significant, or the lesion which was chosen could not be right. Or third possibility is that multiple sites were not taken. Say, for example, in a suspected mycospheric, I would take multiple sites because we know we need to take for IHC, we need to take. So you get a sort of a dermatitis-like picture. The earlier one favorite diagnosis of chronic superficial or chronic non-specific dermatitis. That is, I think, should not be encouraged. So there should be pointers towards it. So these are the usual situations where we get actually very non-specific. There, a descriptive is valuable, but that has to be correlated by the clinician. Whatever input you all give has to be correlated by the clinician because the clinician is actually seeing the clinical picture. That's where picking up the phone and calling actually helps both ways.
Sir, I have a doubt. So what is this excoriation?
Excoriation essentially means it's a linear break in the continuity of the skin. So, നമ്മുടെ മലയാളത്തിൽ പറയുകയാണെങ്കിൽ മാന്തി പറിക്കുക എന്ന് പറയും. This sort of where the nail actually digs and then forms linear breaks in the continuity of the skin.
Epidermis intact ആയിരിക്കും.
Epidermis will be broken. So an erosion also epidermis is broken, ulcer epidermis is broken, excoriation is broken, epidermis is broken. But erosion is very superficial. So like what we see in pemphigus after the blister is broken is actually a very superficial break in the continuity. That is erosion. Ulcer is a little more deeper because the upper dermis is it. So excoriation is usually linear, or sometimes you can also get very pinpoint excoriation, like I showed in DH, dermatitis herpetiformis. That area is only being scratched, and that is why you'll find them picking off the skin. But it is an objective sign of the severity of the itch. We have, like pain, itch is very subjective. So we need objective signs. So one of the objective signs the patient is actually suffering from a lot of itch is excoriation.
So another question. How did the pathologist give a diagnosis of eosinophilic annular erythema when such a clinical diagnosis has not been suggested? Would not a microscopic description is okay?
That the pathologist should be able to answer that. That was new to me.
Wonderful question.
Yeah, so
that's exactly what we are supposed to do. We don't look at alone at their differentials. We have to find out on our own also. So in some cases, when it doesn't, actually this case, I had seen it, and at one glance it looked like an erythema annular centrifugum. But then I started to see eosinophils. Eosinophils, just like an insect bite reaction. So
that is why the first diagnosis was IBR, insect bite.
So I was also thinking of insect bite reaction, but there were too many eosinophils and they were in the interstitial distribution also, which made me look up for lesions causing eosinophils in the interstitium and around blood vessels, and that led to the diagnosis of this particular entity, which is closely related to Wells syndrome, eosinophilic annular erythema. And that fitted in quite well with the histology. And then I asked Dr. Abhay to send the clinical photographs, and I thought it did fit in with the clinical images also. So that's how that diagnosis was given.
And one other input for all pathologists. See, our race is not like the Caucasian race. We don't see erythema as such. We see pigmentation. So sometimes your description may come as pigmentation. So when you see the lesions there, the textbook picture is erythematous, whereas my clinical patient had a pigmented lesion with a slight marginated area. So I think that also should be borne in mind that as a race, we are what we call as type 4-5 Fitzpatrick type. We are little less than the Negroid, but not as fair as the Caucasoid. So we will find sometimes pigmented lesions. We won't find anything.
Okay, another question is refer description okay?
Pardon?
Is refer description okay? That is, we are writing the description and not giving a definite diagnosis.
Depends on the case. If absolutely the pathologist is not able to do a back end and can only give a descriptive diagnosis, I am fine with it as long as something gross has not been missed or a pointer is not there. So that is why we give our clinical differentials. But when you are not able to make a diagnosis at all, descriptive is good enough for me to, but these clues need to be picked up from that description with correlating with the patient's clinical signs.
Then partial treatment can alter the histology and can cause difficulty in arriving at the diagnosis.
Yes.
So
Yes. That is why we need to go back to the clinician and ask whether partially treated. Even the clinician has to ask that history. See, very often being in a referral hospital, I get a lot of cases which have already been treated and attempted at. And then so in such cases, what I do is I ask them to come back after a week, applying either plain calamine lotion or a moisturizer or giving them some symptomatic relief. The original picture will come back. And then I take a biopsy.
Then how common is lymphocytoma cutis?
It's very rare. Yeah, I have seen it more in the Western textbooks, but personally, I have diagnosed, I think once or twice I would have diagnosed it.
A doubt. So parakeratosis refers to scaling.
Yes.
Like that, is there any other clues in the histopathology description which can lead, which can help the clinician?
See, all scales need not be parakeratotic. See, you can have, say, for example, in ichthyosis, you have very thick scales. And those scales just may be hyperkeratotic and the sheet of stratum corneum may be coming off. The presence of parakeratosis only means that there is so much of rapid proliferation, you're finding some amount of nucleated cells in the upper epidermis. So parakeratosis gives a pointer towards a papillosquamous disorder, but does not mean always, and you might find depending upon where you're picking it up also, where the lesion has been. So in the light of the entire clinical and histological findings, the parakeratosis holds significance. Isolated parakeratosis here and there would not correlate always with the skin. And of course, as I mentioned, the site of biopsy.
Then one more question, lymphocytic vasculitis, is there such an entity?
It's a histological diagnosis actually. Neutrophilic vasculitis, lymphocytic vasculitis, all these are histological. We don't usually give clinical diagnosis as lymphocytic. That is only the infiltrate at that point in time which has occurred. That cannot be a reason for a diagnosis. Because leukocytoclasia is an independent diagnosis. There again, it is a common endpoint for multiple diseases. The mere presence of leukocytoclastic vasculitis does not say that it is neutrophils. After some time, when we take a biopsy, this leukocytoclasia may not be there. The next set of cells would have come in.
So I think it's time to wind up. If there are no more questions, Dr. Deepa.
Thank you, madam. On behalf of the IAPM Kerala chapter, I take this opportunity to thank our esteemed speaker of today's webinar, Dr. Abhay Martin, for the wonderful session with, in fact, an atlas of clinical photographs engaging us throughout. And we are not seeing the gross specimens in skin biopsies. These photographs and the clinical aspects are really interesting and new to most of us. So I think all the participants have taken that aspects well. We also thank our dear members for their active participation today. And we also take this opportunity to thank Mindray India team led by our dear Shama and Nikhil for providing the platform and giving assistance for the smooth conduct of the webinar series. So before concluding, a gentle reminder, our next webinar is on next Friday, 7:30 p.m. It is January 10th on general approach to inflammatory dermatosis by none other than our own dear Aravindan sir. So good night to all. Thank you.
Thank you
Thank you.
all.
Thank you.
Once again, thank you, Dr. Abhay, for the wonderful presentation.
Thank you for the opportunity given.
Thank you, everyone, on behalf of Mindray India.
Thank you.